As physical therapists, we're trained to be masters of the musculoskeletal system. We live and breathe muscles, bones, and joints. But what happens when a patient's pain isn't coming from any of those things? What happens when it's all just a masquerade? Today, we're digging into how problems in the GI tract can perfectly mimic common orthopedic issues and why missing those signs can be a really big deal.
Okay, picture this. A patient walks into your clinic. They've got what looks like a classic hip flexor strain. Pain with hip flexion, it's tender in that lower quadrant. Seems like a total slam dunk, right? But what if the true culprit is a medical emergency hiding in plain sight? This is the exact clinical dilemma we're tackling today. This is what we call the musculoskeletal mimic. Basically, it's any time an internal organ refers pain somewhere else in the body, completely fooling us into thinking we're just dealing with a simple strain or sprain. And look, for the safety of our patients, this is one mimic we absolutely 100% have to be able to spot.
All right, so let's jump right in. We'll start with one of the most common complaints we see. I'm talking about that patient who comes in with back pain or hip pain or maybe some abdominal pain, and the story just doesn't quite add up. This is where our skills as detectives really have to shine. And this isn't some made-up hypothetical from a textbook. This is a real-life case. A patient comes in with all the classic signs of an iliopsoas tear: pain when you resist hip flexion, tenderness right where you'd expect. But the clues that didn't fit, the nausea, the fatigue, the pain that just kept getting worse no matter what, those were the clues that really mattered. It's the perfect example of a life-threatening emergency walking into your clinic disguised as a routine injury. So how do we get better at spotting these imposters? Well, it starts by knowing the usual suspects. We're going to focus on three major GI conditions that love to wear a musculoskeletal disguise. We're talking appendicitis, pancreatitis, and inflammatory bowel disease. First up, the most famous mimic of them all, appendicitis. It's a serious inflammation of the appendix, and if it's not caught in time, that appendix can actually rupture, which leads to peritonitis, a really widespread and dangerous infection of the abdominal lining. Now, the number one clue you have to look for is the pain pattern. As you can see right here, classic appendicitis pain doesn't just start where it ends. It usually begins as this kind of vague, dull ache right around the belly button. But then, and this is the key, over several hours, it travels. It migrates down and to the right, sharpening into a very specific point of pain we call McBurney's point. That pain migration is one of the biggest red flags you can look for. So, on top of that migrating pain, you start building your case with other symptoms. Yeah, sure, there's the nausea and fever you'd expect. But for us, the musculoskeletal clues are everything. Is there referred pain shooting into the right thigh or groin? Does the patient tell you that any little movement, even just riding in a car over some bumps, makes the pain way worse? Those are the details that help you separate an organ problem from a muscle problem. Okay, our next culprit is pancreatitis. And this one, well, it's nasty. This is an inflammation where the pancreas literally starts to auto-digest itself with its own enzymes. It's intensely painful and it can absolutely be life-threatening. The hallmark of acute pancreatitis is the severe upper abdominal pain that feels like it's boring a hole straight through to the back. But here's the key for us as therapists. The pain has a really clear postural component. It gets worse when they're lying flat on their back, and it gets better when they sit up and lean forward. If a patient ever tells you their back pain feels better when they curl up into a ball, your visceral pain alarm bells should be going off like crazy. And finally, let's talk about inflammatory bowel disease, or IBD. Now, this is an umbrella term, and it is super important to know that it is not the same thing as irritable bowel syndrome, or IBS. IBD involves chronic inflammation and actual structural damage to the bowel itself. So under that IBD umbrella, you've got two main players. There's Crohn's disease, which is kind of like the globetrotter. It can pop up anywhere along the GI tract, literally from the mouth to the anus. Then you have ulcerative colitis, which is more of a homebody. It stays exclusively in the large intestine and the rectum. Knowing this helps because it affects how and where symptoms show up. Now, while you'll see the GI symptoms you'd expect, the absolute crucial point for a PT are the extra-intestinal manifestations. Get this, about 25% of people with Crohn's first present with arthritis. This can be a weird migratory joint pain that just hops from one joint to another, or it can be hip pain that's actually coming from an iliopsoas abscess. So if you see a patient with joint pain and seemingly unrelated stuff like skin lesions or eye redness, you have to start thinking IBD.
Okay, we've identified the suspects. Now for the really practical part. How do we actually screen for them in the clinic? Let's build out our screening toolkit with a few key tests you can do quickly and easily.
This is a really common point of confusion, so let's break this down. Palpating for appendicitis at McBurney's point is different from palpating for an iliopsoas strain. For McBurney's point, the patient is lying flat on their back, and you're finding that spot about halfway between their hip bone and their belly button. But to specifically test the iliopsoas, you first need to put that muscle on slack. So you bend the hip and knee to 90 degrees, and then you palpate about a third of the way from the hip bone. That small difference in position and location is critical.
The next tool is the rebound tenderness test, also known as Blumberg's sign. This is our go-to test for peritoneal inflammation. So you start by placing your hand on an area of the abdomen away from where it hurts. You press down nice and slow, but deep. Then you quickly pull your hand away. And here's the magic question. Was the pain worse when I was pressing down or when I let go? A sharp jolt of pain on the release is a positive sign. And a huge safety tip. Always do this test last because it can really provoke pain. And these images show the technique perfectly. In that first picture, you see the slow, careful depression of the abdominal wall. In the second, the hand is quickly removed. See, it's not the pressure itself that's the key part of the test, it's the sudden recoil of everything inside when you let go. If that lining, the peritoneum, is inflamed, that sudden movement will cause a sharp, localized pain, and that is your positive finding. So, you've done your screening and something just feels off. Your gut is telling you this isn't straightforward. What's next? This is the most important step of all, taking decisive action and making the right referral to make sure your patient gets the care they need.
Let's be crystal clear. These are the red flags. If you get a positive McBurney's point or a positive rebound tenderness test, or if you suspect an abscess, this is not a call your doctor on Monday situation. This requires immediate medical attention. Your job is to get them to an urgent care center or an emergency room right away. And then we have the yellow flags. Now, the situation here may not be an immediate emergency, but it absolutely requires a conversation with their physician. This is stuff like back pain in someone who uses a lot of NSAIDs, which could point to an ulcer, or that classic IBD pattern of joint pain that shows up with skin or eye problems. If the pain pattern is tied to eating or their bowel function, a referral is a must.
Please never, ever underestimate your role in this process. Because we spend so much time with our patients and we perform such detailed physical exams, we are often the first line of defense in spotting these systemic issues. A thorough screening doesn't just make you a better therapist, it can literally save a life. So, I'm going to leave you with a challenge. Based on what we've covered today, what's one screening question you'll add to your next evaluation? Just one question about their GI health or systemic symptoms that could help you spot one of these mimics. Because being a great detective isn't just about solving the case that's right in front of you, it's about knowing when you might be working on the wrong case entirely.